Welcome to this rapid-fire clinical explainer. Today, we're aggressively targeting high-yield wound healing and scar management board questions. Let's get right to it.
We've got two core modules today. First up is wound healing and pathology, and then we'll hit diagnosis and management.
All right, Section 1, Wound Healing and Pathology. Question 21. What is the most common cause of impaired wound healing overall? Is it A, foreign body, B, poor surgical handling, C, infection, D, steroids, or E, malignancy? The correct answer is C, infection. Lock in this exam pearl. Infection is the most common culprit because it traps the wound in a prolonged inflammatory phase. And for bonus points, the most common organism you'll see here is Staphylococcus aureus. Moving right to question 22. Which of the following is an incorrect statement about wound healing? A, hexosine amino acids are formed. B, collagen deposition occurs in the lag phase. C, the mechanical factor is collagen. D, clean wounds heal with minimal scarring. Or E, vitamin C is required. Well, the correct answer is B. Here's your exam pearl for the lag phase, which covers days 1 through 3. During this initial time, hemostasis is active, and inflammation is transitioning from neutrophils to macrophages. But notice what's missing. Collagen deposition is strictly at 0. Collagen synthesis actually doesn't kick off until the proliferative phase. Next is question 24. What is the specific collagen makeup found in a hypertrophic scar? A, type 1 and 3, B, type 1 and 4, C, type 3 and 4, D, type 4 and 5, or E, none. The correct answer is A, type 1 and 3. Your exam pearl for this one is that in hypertrophic scars, you'll see an increased amount of disorganized type 3 collagen mixed directly in with type 1. It's disorganized, sure, but remember it's notably less dense than what you'd see in a full-blown keloid. Okay, let's jump straight into Section 2, Diagnosis and Management. Question 23. You have a scar that actually grows beyond the original wound boundary, accompanied by itching, after a completely symptom-free interval. What are we looking at? A, keloid, B, hypertrophic scar, C, squamous cell carcinoma, D, basal cell carcinoma, or E, Kaposi sarcoma? The correct answer is A, keloid. Let's lock in this keloid exam pearl right now. Keloids are notorious because they extend beyond the original wound, they have a delayed onset, an incredibly high recurrence rate, and they're more common in darker skin. Compare that instantly to a hypertrophic scar, which strictly obeys the boundaries of the original incision. Question 27. What is the key feature of a hypertrophic scar? A, female predominance. B, genetic predisposition. C, the sternum is a common site. D, it appears within 4 weeks. Or E, it never regresses. And the correct answer is D, it appears within 4 weeks. Here is your hypertrophic exam pearl. These scars appear rapidly, usually within 4 to 6 weeks, and they actually may regress spontaneously over time. That is a huge contrast to keloids, which have a delayed onset and show progressive, non-regressing growth. Question 25. What is the single most common site for keloid formation? A, eyelids, B, joints, C, scrotum, D, palm or sole, or E, sternum? The answer is E, the sternum. Your exam pearl here is straightforward but absolutely crucial. High tension areas are highly keloid prone, so the absolute most common site is the sternum, specifically that pre-sternal area. Other high-risk zones to watch out for include the earlobes, the shoulders, and the upper back. Question 26. Which of the following is true regarding a hypertrophic scar? A, response to pressure therapy. B, more common in females. C, more common on the face. D, more common in whites. Or E, always excised. The correct answer is A, it responds to pressure therapy. Follow this stepwise exam pearl. Your first-line treatment is always pressure therapy and silicone sheets. Second line is intralesional steroids. You really only consider surgery if there's functional impairment or if you're dealing with a fully mature scar. Question 28. What is the correct statement regarding scar surgery principles? A, keloids occur randomly. B, histology is the same in a keloid and a hypertrophic scar. C, keloids appear early. D, a hypertrophic scar can be excised and closed primarily in selective cases. Or E, none. The correct answer is D. Your hypertrophic exam pearl here confirms that these scars can actually be excised with a low-tension primary closure. On the flip side, if you try to excise a keloid alone, you're guaranteeing an extremely high recurrence rate. Question 29. What is the absolute first-line treatment for major keloids? A. Excision alone. B. Radiation alone. C. Intralesional steroids. D. Pressure garments. Or E. None. It's C. Intralesional steroids. Your first-line exam pearl explicitly identifies intralesional steroids, typically triamcinolone, as the go-to. As adjuncts, you'll often combine this with 5-FU and silicone sheets. Remember, to avoid surgery as a primary option, it's strictly a secondary backup. Question 30. What is the best treatment for a recurrent keloid? A. Steroid alone. B. Excision plus radiotherapy. C. Excision plus steroids. D. Excision alone. Or E. Pressure therapy. The correct answer is C. Excision plus steroids. Here is the exam pearl for this. Recurrent keloids strictly mandate combined therapy. So the best approach is excision combined immediately with intralesional steroids. What about radiotherapy? That is detailed as a last resort, reserved exclusively for highly resistant or multiple recurrence cases. Finally, let's do a final exam pearl check. How will recognizing the exact timing and collagen density differences between these scar types immediately change your surgical approach tomorrow on the wards? Think about that and let it guide your clinical decisions.